Welcome to my podcast, Why Didn't Anyone Tell Me This? With my guests, we are discussing reproductive health issues, questions you may have about your health, and debunking some of the many myths. And today, it's a great pleasure to talk to Professor Tim Child about how to get pregnant naturally and with assisted conception. Tim is Associate Professor of Reproductive Medicine in the Nuffield Department of Women's and Reproductive Health at the University of Oxford. Tim studied medicine at the universities of Cambridge and London, followed by postgraduate training in Oxford and a 2-year fellowship at McGill University in Montreal, where he worked on a really innovative technique called in vitro maturation, a drug-free version of IVF. He returned to Oxford and in 2007 led the team behind the first UK babies born using this technique, who were twins. He got his research MD from the University of London with a thesis titled Clinical and Ultrasound Prediction of Outcome in Unstimulated Oocyte In Vitro Maturation Cycles. I'm sure that doesn't make any sense to anyone, but Tim and I will be talking about this new technology later on. Tim is on the board of the Human Fertilisation and Embryology Authority, which is called the HFEA, and chairs the Scientific and Clinical Advances Advisory Committee, which I used to be on. So we're going to talk about the HFEA as well during this podcast. And Tim was a member of the 2013 NICE Fertility Guidelines Group. He is co-author of the UK's highest selling obs and gynae textbook and has published over 100 research papers and chapters. And as I am, Tim is a firm believer in evidence-based medicine and has undertaken many trials assessing assisted conception interventions. He runs regular patient-focused Instagram lives on his channel at Dr. Tim Child. So again, he's very passionate about education as I am. And please follow him on social media and watch his great videos. They're very, very educational. So that was a long introduction. Welcome, Tim.
Well, thank you. I'm tired myself after listening to that. I apologise if it's being long.
I know, I always hate hearing my introductions. Now, I always ask my speakers on my podcast at the start to tell us about what led them to want to be doing their current job. So what led you to want to work in this field?
Yeah, well, I mean, when I was at medical school, when you're in the clinical part of medical school, you rotate every 1 to 2 months through different specialties. And I enjoyed surgery, I enjoyed medicine, and one of the later ones I did was obs and gynae, and I just loved the thrill of working on labour ward and the excitement, the adrenaline rush. Obviously, delivering, bringing new life into the world was just incredible. But that was at the Royal London Hospital, and this is in the very, very early 1990s. Fortunately, I was introduced to the IVF team at the time there as well. So I had a sort of bit of a look at IVF. I then thought obs and gynae is the best career choice for me because it sort of combines everything I enjoy about medicine into one. And then again, very fortunately, my first job in Oxford was with Professor David Barlow, who led the IVF unit in Oxford. And so again, I was introduced back into fertility and IVF very early on, and I really just stuck with it from there. Zero regrets about my career path.
Yeah, we do work in a very dynamic and interesting field that really keeps us on our toes. But before we go into assisted conception, this is the first podcast in what I'm calling my new mini series, and this mini series is on motherhood. So I wanted to first ask you, what's your advice that you would give people who are trying to get pregnant? Because in schools we're taught how not to get pregnant, but we're never taught how actually to get pregnant. So what's your advice for those trying?
Well, I think for those trying or those thinking about trying, I think it's first of all to take a step back and just look at your general health. So try and optimize health. And if this is for a heterosexual couple, male and female health, look at optimizing your body mass index, regular exercise, eating healthily. There's a lot of information around at the moment about the Mediterranean diet. So a nice sort of wide ranging diet. Smoking is very bad for fertility. Alcohol and caffeine, probably not great, so just be sensible about lower levels about that. And I think just get informed, really. I think particularly if people are struggling getting pregnant, then it's even more important to look at those lifestyle things that we can all, obviously all of us can improve our lifestyle. And then I think get informed. Having information lets you make informed choices about what to do next.
And yeah, I'm very much up on the lifestyle, and I want to try and make sure that we really understand how important lifestyle is throughout our reproductive health. So you and I, we see patients, they're coming when they're trying to get pregnant, and we realize that it's not optimum how they're living. And then we're also seeing women that come in the perimenopause. So it's really good to try and get that sorted out as soon as we can. There's a lot of money in fertility. So we see so many dietary supplements and other tests and things that people can do. So what about the supplements? Are there any supplements that you would suggest for anyone trying to get pregnant?
Yeah, all women who are trying to get pregnant or soon planning to try and get pregnant should be taking folic acid and vitamin D as a minimum. Folic acid is there to help reduce the risk of spina bifida and other neural tube defects. It's not there to improve the chances of getting pregnant. And vitamin D, again, is just general health, particularly during pregnancy. Beyond that, whether there's any benefits in taking other supplements is really very, very unclear, despite what all the supplement companies make. And because the supplements are all food products, they're not drugs, they don't need to pass any of the same regulatory requirements that a drug would, which means that the manufacturers can make all sorts of claims which are just based on very poor quality or zero evidence. Having said that, I think if people feel happier doing something, there's nothing wrong with taking a supplement. And I think, the Pregnant Care Conception on the female side, nice and cheap, it's got everything in it. And on the male side, the Wellman or the Testim, any of those sorts of ones are absolutely fine. They're pretty cheap. I would not go down the route of paying lots of money for more high-tech type supplements, because I know there's no evidence of any benefit.
Yeah, the social media is full of all these various lotions and potions that people can take, especially women. And I wrote a lot about that in my book. When I looked at the evidence, it was all pretty low, and I think people can get in a real knot with the pressure of thinking they need to be taking this and that and the other, and paying extortionate amount of money for things, as you said, there's no evidence.
And particularly sometimes what happens is blood levels are measured of various things, which first of all, we don't even know if it's worth measuring these things. Secondly, we don't know what the ideal range is, or even if there is an ideal range for whatever serum level of rhubarb or whatever it is you're measuring. And then that leads then into people taking supplements for which, again, we just don't know. So I think with all these things, for tests and whatever, if it's fine having tests for things, but there needs to be some logic to the test. And very importantly, does having the test change the management, and does changing the management lead to a better outcome? And there's so many gaps in that pathway.
Yeah, while we're talking about tests, so the fertility tests that you can buy in Boots, and I think you can buy it in Boots. I know Superdrug, I know you can buy fertility tests on Amazon and from lots of different companies. And I did a podcast recently about this, about the testing. So with Tessa Kopp from Australia. So what do you think? Is there a fertility test? Because actually I've just recorded this morning the podcast with Mel Johnson, and she said the advice she would give women in this field who are thinking of becoming a solo mother is to go and get a fertility test. And actually, I didn't want to sort of get into the whole discussion about it, but you and I can have a couple of minutes. So if women are trying to
Yeah,
get pregnant naturally, is there a fertility test that they can go and have?
probably not really. Actually, if you're trying to get pregnant naturally, if a woman has got regular menstrual cycles, vast majority of women with regular cycles are going to be ovulating, and so even in the States now, the American guidance, ASRM guidance, is don't go having progesterone levels measured if you have regular cycles, because it doesn't tell you anything. The test that is spoken about all the time is the AMH test, or anti-Müllerian hormone, which looks at ovarian reserve, which is a very useful test, but it is not predictive of the chance of getting pregnant naturally in women with regular cycles. It's used to maybe diagnose why women aren't having regular cycles, and it's a very important test once you start getting into IVF. Or I guess if you're thinking about egg freezing, but various other things. But for most people who are looking at getting pregnant naturally, I honestly don't think there are any tests that are of any benefit. There's no benefit of measuring the microbiome, the sort of vaginal levels of different bacteria, etc. Nowadays men can buy home sperm tests, which is a screening test. I think there might be some value in those, but you can get those done free via the GP rather than paying for them. I guess there may be some value in having a home sperm test compared to not doing any test at all, if you're failing to get pregnant. But at that point, you should probably be going to see a doctor anyway and having a proper validated test in an IVF lab done.
Yeah, I totally agree. Fertility is big money. There's millions and millions in the world of fertility. So I totally agree with Tim. If our advice would be, if you want to get pregnant, try naturally. If you can't get pregnant naturally, go and see your doctor. And there's lots of tests that they will do, proper tests, to help you along the way with that. Are there any, in schools, as I said, we're taught about how not to get pregnant. So you've mentioned that if someone's got a 28-day, roughly 28-day cycle, roundabout, we're all very individual, so it won't be direct, directly on the nose every month,
If
28
it's
days.
regular, if it's just regular, yeah.
Yeah. So a regular cycle. When should they know when is the peak time? So tell us a little bit about the fertile window. When's school, we're normally taught that you can get pregnant any day of the month because they're trying to stop teenage pregnancies, but that's not
Scare
true.
you.
Yeah. So tell us about the fertile window.
Yeah, so for women with regular cycles, and you're quite right. I think in a textbook, it's always written down as 28 days, and it's split into 14 days, 14 days. But the 28-day thing is very misleading. And if cycles are every 25 to 35 days and are regular, those are regular cycles and highly consistent with ovulation. And so the first part of the menstrual cycle is called the follicular phase, and that's when the follicles are growing in the ovaries. And that can be pretty variable actually between women. So when you get different women with different length cycles, it's that follicular phase which is the bit that varies. It could be 7 days, it could be 21 days. Once there's a big follicle, there'll then be ovulation happening, and then the luteal phase, which is the time between ovulation and the period, is generally about 12 to 14 days, and that's pretty fixed between women. So to get pregnant, there needs to be sperm around the fallopian tubes where there's an egg, in that middle bit around the time of ovulation. Now, in the NICE guidelines that you mentioned I was involved with, we looked at this quite closely, and there's no evidence at the moment that for women with regular cycles there's any benefit in measuring or timing intercourse based on urine LH kits and things like that. Some women like to use urine LH kits because they feel it gives them more information about their body, and that's fine. But many women report that it makes them feel more stressed, they're more worried, they're more anxious, and they might even be delaying intercourse, waiting for an ovulation that maybe the kit has missed. And so that month they've actually even it's been contraceptive using it. So my advice always is don't bother with the urine LH kits. And I can't think of a single time over my long times, many years of seeing patients, where I've suggested using one of those kits for women with regular cycles. So in answer to your question, the fertile period is the few days around the time of ovulation. The sperm lives for 2 or 3 days in the tubes. The eggs can live for a couple of days as well. So around that time. But the NICE guidance is really have sex every 1, 2, 3 days through the cycle without trying to focus in on timing, and that's what the NICE guidance is.
And the urinary LH test that you mentioned, so that's I think it's marketed in the shops as an ovulation test. So that's measuring this hormone called luteinizing hormone, which rises about 24 to 40 hours before the egg's going to be ovulated. So it can tell us when that's going to happen. But as you say, if you've got a regular cycle, then just have lots of sex. And then we're going to talk now about what happens when you don't get pregnant. So what about those women with an irregular cycle?
So that can be trickier. And so I think, if women have irregular cycles, so it's particularly if they're infrequent and irregular, rather than being every 15 to 25, if they're very, very frequent and irregular, then I think you need to be seeing a doctor or a gynecologist just to make sure see what's going on there. If they are very infrequent, which is the commoner thing, the commonest cause of that is polycystic ovarian syndrome, PCOS women, which probably about 5% of women have. So if they're very infrequent, then you may still be ovulating and you might still get pregnant. But if you've not got pregnant after a few months, that definitely is the time to start to speak to a fertility doctor, because there are very, very good, first of all, investigations to make sure it is PCOS that's causing the irregular periods and it's not because of a lack of eggs or some other problems with hormones. But there are very good fertility treatments for women with PCOS, for irregular periods or lack of ovulations, particularly if it's due to PCOS. But it's very important if you have irregular periods, it's very important to look at the lifestyle side of things, particularly body weight, because being too thin or overweight can stop women ovulating. And the way I look at it is sort of nature's way, maybe, of saying, okay, well, maybe now is not the great time to get pregnant. Either the woman's too thin or too overweight, and the risks of pregnancy go up under those circumstances.
Yeah, I think we've tied ourselves in a bit of a knot nowadays, because there's whole thing about body shaming. You're not allowed to talk about weight, but with fertility, as you said, we have to
Mm.
consider it. So when we've been producing educational information, people said, "Oh, you can't say this about weight and that about weight," but that is the data, isn't it? If you're too thin, too overweight, then you might not get pregnant naturally.
Yeah, and it's a risk factor. So, and it's not just about getting pregnant; it's the risks of pregnancy as well. So, the average BMI is obviously gone up and up and up in the Western world constantly, but we know that men and women have lower fertility as the BMI goes up. That's why the NICE guidelines for IVF want the BMI to be less than 30, because we know that as the BMI goes from 30 and up, it's not that IVF won't work, it's not that people can't get pregnant naturally, but the chances of IVF, or chances of a successful pregnancy, go down. The risks of pretty big complications in pregnancy, such as gestational diabetes, preeclampsia, which is high blood pressure, bleeding before, during, or after delivery, cesarean section, wound infection, everything goes up with BMI.
Yeah, and so we've given some advice now about understanding your fertile window, how often to have sex, and about regular and irregular periods. So, how long should a couple, try to get pregnant? Um, I mean, I've been there, that time when that period comes every month. I've just been doing some period focus groups, and we spend most of our life dreading our period coming. And then when we're trying to get pregnant, we dread it. We want it not to come. So
Yeah.
it's always a bit of a quandary. So, how long should a couple, try to get pregnant before they go and not without success, before they see a specialist or a doctor?
So the NICE guidelines recommends 12 months, but that is very much if you are fit and well, regular cycles, there's nothing in your history which makes you think there might be something wrong, such as having had maybe surgery or severe endometriosis or trauma, or to the abdomen or the groin, the groin in a man. So if everything's absolutely fine, regular cycles, and you're probably below the mid 30s, I think it is okay to leave it up to 12 months, whilst focusing on lifestyle, etc., and getting informed. But if there are any of those things that I mentioned, and the suggestion is that by 6 months, it's worth, particularly irregular periods, or the woman's maybe later 30s, or there's any history of any abnormality or medical illness, then I think by 6 months it's worth having an initial chat, probably with a GP. The GPs have got guidelines they can work to get some evidence-based tests done, and then potentially to refer you in on the NHS to your local hospital for secondary care, where they might be checking your fallopian tubes and doing sperm tests, etc.
So you mentioned the mid-30s, the dreaded mid-30s. So tell us a
Mm,
little bit about the life of male fertility and female fertility,
mm,
and this issue
mm.
with our mid-30s for women.
Yeah, it's very. I've had so many patients over the years who've come in, and the female patient will, she might be 34, and for whatever reason she just thinks, on my 35th birthday it's game over. That's it. Falling off a cliff, eggs have gone, or the eggs are rotten, or whatever it might be, all the different things that I've heard people talk about their eggs. And so I don't know where this 35 thing comes off. I mean, it's fair to say, so, as you all know, Joyce, more than me, but so, women are born with 2 or 3 million eggs in their ovaries. Those are all the eggs that the woman has, and the genetic quality of the eggs does go down over time for whatever reason, as does the number of eggs. Now, we can measure the number of eggs very easily nowadays with an AMH blood test. The genetic quality of the eggs, there's no test for it apart from really asking someone how old they are. And it is a strong link. And so that drop off in a woman's fertility as she goes through her 30s is more to do with the genetic quality of the eggs, and therefore the embryos, than the number. The number's not as important actually as the genetic quality, which is related to the age. But it's not that the woman gets to 35 and then the quality suddenly drops down. It drifts down from the mid 30s. And so if you look at any success rates from an IVF point of view, particularly from big databases such as the HFEA one, you will see that up until the mid-30s, the success rate is the same whether you're 28 or 33. There's no difference really. And then from about 36, 37, it does start to drift down a few percent per year, but it's not a roller coaster ride down. Now in men, there is a drop off in male fertility with age, but there are obviously the Mick Jaggers and the Charlie Chaplins of the world that are still having children in their 70s and 80s and whatever. So it's obviously very, very different. I feel sometimes it does seem unfair. I accept that, and I've seen a few things where I think it's been overstated, the drop off in male fertility, and whether that's in a sense to try and make it more worrying for men as it is for women, I don't know, but it's not the same. I mean, sperm donors in the UK have to be less than I think it's 45 now, because for older men there is a bit of a higher increase of miscarriages and also perhaps some genetic abnormalities with men that are much older, but you'll notice that's a good 10 years or more later than women, and it doesn't get down to zero, which it does unfortunately in women.
Yes, when I'm giving lectures, I always say, shout out some famous celebrity older men who have fathered children, and depending the age of the group, but it's normally people like Mick Jagger.
Yeah.
But then for women, it's not. We are seeing a lot of celebrities now, with female celebrities having children in their 50s. So maybe we'll talk about that in a minute when we've got a couple more questions. One more question about natural
Yeah.
conception, then we'll move on to assisted
Mm.
conception. But they certainly, it's highly, highly unlikely that it's a natural pregnancy because, what's your
It won't
view on
be.
your chance of getting pregnant over 40 naturally?
So, I mean, again, in women with regular cycles, so generally we say that if you just take women who are trying to get pregnant as a whole, about 80, or couples, about 80% will get pregnant in the first 12 months of trying, and that's really where the NICE guidelines 12 months comes into it. So that's 80% of people get pregnant in the first 12 months of trying, with no treatment at all. And very importantly, of those that haven't got treatment in the first 12 months, if they do tests and the sperm is fine, tubes are open, and the woman's got regular cycles, half will get pregnant in the second 12 months of trying. So you're up to 90%, which is really why the NICE guidelines recommend for most people waiting 2 years before considering IVF rather than jumping in early. Now, for women as women get older, the chance of getting pregnant naturally or with IVF does go down. But unfortunately, the double whammy is the risk of miscarriage really goes up and up and up. So if you multiply together a lower chance of getting pregnant and then sadly a higher chance of miscarriage, that really explains why the live birth rate does start to drop down in the very late 30s and into the 40s significantly. So in answer to your question, I'd say in a woman's early 40s, and again, 41 is very different to 45 years of age in women. That early 40s is a time of big change. I'd say in the early 40s, it may be that over 12 months, the chance of having a baby is not up at the 70 or 80%. It could be down in the 15, 20% or so. So it's not a rare thing to happen, but the miscarriage rate could be 50 or 60%. So it can just be unfortunately more pain and anguish to get to that success rate point. But obviously there are many, many women who are having natural pregnancies and successful natural pregnancies in their early 40s. It's not a rare thing at all.
But the celebrities are in their 50s, but we'll come back to that. We'll come back to that.
Yeah, exactly. Yeah.
Yeah. Before we go on to infertility treatment, what do you think are the biggest myths around natural conception?
Well, I think you said it depends who you talk to. If you talk to sort of younger women who maybe even haven't thought about getting pregnant yet, and they're thinking about their school days, it's about having sex once. That's it. You're pregnant, and then once people get through and start looking into getting pregnant, particularly if it's not happening naturally, then they realise that it's not so straightforward, and it is considered normal to take up to a year. So I think some of the myths would be that I do see patients sometimes who maybe they've come off the pill, they've not got pregnant by 3 months, and are thinking, well, what's happened here? Because everything I thought meant that I was going to get pregnant straight away. In fact, even for fertile women, the pregnancy rate per month naturally might be 15 or 20%. So on a month by month basis, most people do not get pregnant. So I guess one myth is that that it's easy to get pregnant for everyone, and it's not. It's normal to take a number of months to get pregnant. I guess sometimes you see myths about, I don't know, eating pineapple or eating McDonald's chips after sex
Ugh.
increases pregnancy. I mean, there's so much stuff like that out there, and that's partly why you mentioned earlier on. It's partly why I started the Instagram channel, which was very much focused on patients, just trying to myth bust some of the stuff that last year I hadn't really engaged with Instagram at all, and I looked at it last year. I was blown away by the amount of bollocks on on Instagram. I really was, actually, written by people who know nothing about it and maybe been on a weekend course doing something or other. I don't know. And I thought, well, this is, it doesn't take much of my time to, to do that sort of stuff. And you know this more than I do. You've been doing it longer than me. And yeah, really myth busting, really.
Yeah, but it frustrates me that people like you and I, rather than it annoys me that we've got to spend our time debunking myths, and obviously social media. There's great things, as you said. There are great things about some social media, but all
Of
this
course.
crap out there, it's just unbelievable. And for the menopause, I've just got the same on the work that I'm doing on the menopause, which is equally as non-evidence based, and people out there who are not qualified in our view to be doing this.
Mm,
And we've done an audit of Twitter and had a look at who's producing some of this education inverted commas stuff. And we're just embarking on a project on TikTok, and I've been having a look at some of the TikTok videos about reproductive health, and young people do know this. Young people we've been talking to, they know that some of the information on TikTok and things is not correct, but they said they don't know how to differentiate what is correct and what's not. So I'm always encouraging people like you to get out there and do it. So well done. Everyone should,
yeah.
if they want to know anything, listen to
Yeah.
Professor Tim Child. Don't listen to someone who's just got a lived experience, which is, if their lived experience is
Well, it's
valid.
not. I do. I always have to, and I make a real point actually on the live of, there is a lot of rubbish that is spoken by doctors. So of course it is not correct that everything that a fertility doctor or a doctor generally says is true, and there may be reasons for that. It might be other agendas going on. Maybe it's a business thing. I mean, there's lots of things that are said out there which aren't correct. But I think that at least when things are coming from people who have been appropriately trained, and very importantly, and a good example I think is there's a lot of stuff out there from in the nutrition dietitian type space, which is very, very interesting. And obviously with the access of people to social media, and so access of people to this sort of information on dietitian nutrition stuff has just gone through the roof. And I think 15 years ago it was almost impossible to get that information, so that's very, very good. But I also see that a lot of it has been commercialized by the people working in that space, because they are putting stuff out there to get more people to either buy their books or go online and do their courses or consult with them or whatever. That's not a bad thing, as long as people go into it with their eyes opening, just being really aware that maybe some of the stuff that they're being told, isn't evidence based. Maybe they don't care it's not evidence based, but just to be aware.
Yeah, you're totally right. That there's lots of medics and scientists who are giving out incorrect information. So
Yeah.
unfortunately, you can't just think, oh, they're experienced person, they're a professor or someone, I'm going to believe them. But also, some of their lived experiences are really excellent. So having just interviewed Mel Johnson
Yeah.
on solo motherhood, she's got a unique experience that we haven't experienced. So her contribution
Mm.
to supporting people going through that journey is really, really valid. But unfortunately, in between, there's a lot of myths that we spend our life debunking. We've got to do it, so we'll just go with it.
Yeah. Yeah.
So let's move on to fertility treatment or infertility treatment. If someone's not got pregnant and they're wanting to take the next steps, what should they do? Go and see their doctor, I suppose. But so tell us what they should do. If they haven't got pregnant, go and see their doctor.
Yeah. So not getting pregnant again. As I said earlier on, look at yourself first: lifestyle, nutrition, diet, all that sort of stuff, just to optimize things. But very importantly, at that point, it is important to start to seek some help. And sometimes I'm surprised. I do sometimes see people who, for 2 years haven't for whatever reason haven't spoken to anyone. a professional yet about their lack of conception, and now maybe that was the right thing for them, but I think that's a shame because things would have moved on during that year. Fertility may have dropped down a bit. So if anyone's worried about their fertility, there is no problem with speaking to someone earlier, and that might be the GP, or you end up going to see a private fertility doctor if you're not going through the NHS system. And nowadays people can have open access to, you don't need a referral to go and see a private fertility doctor. You can do your homework on the net, and then do that. And now it might be that you go to see whoever you see, and they say, well, okay, we can do a couple of tests, but I think the best thing to do is go away and keep trying for 6 months or so. But if that's what you want to do, if that's more information and more decision making for you, then that's great. So I think by 6 to 12 months, between 6 and 12 months, then yes, either the GP first, then probably GP would refer you into hospital care, to a fertility clinic in a hospital, or you potentially just go, cut the mustard and just go straight to see a fertility doctor privately.
Yeah, and you've worked in fertility treatment for many years. So what are the most common causes of infertility that you've encountered?
Well, it's roughly divided into thirds, really. So for a third of heterosexual couples who are failing to get pregnant, it's primarily female. For a third, it's primarily male, and for a third, it's unexplained. It may be between 20 and 30% it's unexplained. So on the female side, the two big ones would be lack of ovulation, so the irregular periods we spoke about already, or blocked fallopian tubes. They would be the two big ones on the female side. On the male side, problems with sperm count or motility, which is percentage swimming forward. But sometimes what you see is there's a bit of a mild factor on the female side and a mild factor on the male side, and those two things add up together. That probably, if one side was completely okay, it would compensate for the side that's mildly abnormal. But sometimes you can just have a couple of abnormalities there, which is why you'll sometimes see that it's mentioned that up to 50% of failure to conceive, there is a male factor in some way. And that's what I mean. There may be a bit of a mildly low sperm count that's with a bit of a problem on the female side, it's enough to tip over the edge. Now, the unexplained fertility is really frustrating, and that means that the tubes are open, the woman's ovulating, and the sperm tests are completely fine, and we don't know why the woman is not getting pregnant, and that's frustrating for everyone involved in it. But very importantly, from a treatment point of view that I know we'll come on to, the IVF success rate, if that's what the person goes into, is the same regardless of the cause of infertility. So whilst people get frustrated about not having a diagnosis, sometimes you can't fix the diagnosis, you can't fix the underlying problem. And if you end up with IVF, it sort of doesn't matter.
Yeah, so that leads us nicely into talking about the different treatments. So most people have probably heard of IVF and know a bit about that. But let's start at the beginning. So if a couple came to you, unexplained infertility, everything's looking good, and they're relatively young, what would you do first? What are the different types of treatments that you may offer them along their journey?
Well, I think probably step back before that, because if a couple came, a woman came and she had irregular periods, so lack of ovulation, and we thought it was something like polycystic ovarian syndrome or PCOS, which is very common. There's a really good first line treatment now called letrozole, which is a tablet. The traditional first line treatment is a drug called Clomid or clomiphene that's been around for 60, 70 years now. And that's a tablet women take for 5 days. It can get them ovulating. But I think Clomid's a bit old school now. Letrozole in big randomized trials has been shown to have a significantly higher live birth rate for women with PCOS. Usually GPs can't prescribe that, so you would need to be seeing a fertility doctor, NHS or privately, for that. Now, it used to be 10, 15, 20 years ago, sometimes women with regular cycles with unexplained infertility would ask for and would be given drugs like Clomid, so ovulation drugs. But that has been shown to not be beneficial. So if the woman is ovulating, there's no point in giving her ovulation drugs. It's like giving glasses to someone with 20/20 vision. It doesn't do anything. But if you have a couple who come in and they have unexplained infertility, so everything's absolutely fine on testing, again, if we go back 10 or 15 years ago, the usual first line treatment was something called IUI, or intra, which means inside, so intrauterine insemination, where the sperm was concentrated and injected in the uterus at the time of ovulation, and sometimes some drugs were given to help stimulate that. And then some randomized trials where women were randomized to have IUI or just try naturally suggested there was no difference in live birth rates, so IUI didn't help. So the NICE guidelines in 2013 suggested that IUI is not used for people with unexplained infertility, and it sort of killed it off overnight, really. So nowadays, for couples with unexplained infertility, you do the test to make sure there's no obvious underlying reason. You might do a laparoscopy, so a keyhole surgery operation, if the woman has some symptoms suggestive of endometriosis, so maybe pain on intercourse or pain around the time of menstruation, and then, but really, once people get up to towards 2 years of failing to conceive with unexplained infertility, by that time, really IVF has been shown to be the most appropriate treatment. If the woman's a bit older, she may be considering stepping into IVF earlier, but that might not be NHS funded. And just a very final thing to say, for the only time we really use IUI now is if we use donor sperm. So IUI is a very good treatment with donor sperm for same-sex female couples or single women.
Yeah, so back in the day when I had my treatment over 20 years ago, it was recommended that we went through quite a few of these IUI cycles. I knew the
Mm,
results weren't that good at the time. I can't remember how many I
yeah.
had, but it was, it was quite difficult to go through with such a low chance of success. So it's great now that that's all been updated, and things within IVF they do
It's
get
very
updated.
it's very interesting though that on the continent they use IUI a lot. So when this all came out 10 years ago, the NICE guidelines, and as you mentioned, I was one of the I was the IVF person on the NICE guideline committee. There were other fertility people as well, but it was felt that, as I said, that IUI was not beneficial. It was no better than just trying naturally. And if you started stimulating with IUI, the studies that suggested IUI was beneficial were all American studies, really from the 1990s, where they were giving really high dose stimulation. And yes, more people were getting pregnant with IUI compared to trying naturally. But in one of the studies, the triplet rate was 10%. So the risk of losing a baby was so high that we just felt that in the UK practice, it was completely not acceptable. So on the continent, they do use IUI still quite a lot, and they think it's very odd that in the UK we don't use it at all. Now the NICE guidelines are being redone at the moment. I'm not involved in it, but it's all being looked at again, and so there have been some more studies more recently that perhaps have been a bit more pro IUI. So I'm waiting with bated breath to see whether maybe IUI, may perhaps in some patient groups and at certain times of trying, maybe comes back into the fold.
Oh, thanks for that update. It just shows that we do research, we look at the data, and we alter things. So I think that's really important, and that's how you and I practice evidence-based medicine. We make sure we're up to date with
Mm,
what's happening, and we should change our views. And things sometimes, as you say, they might go around in circles, but that's science. We've just got to go with the data.
yeah,
And talking about data, so you've been involved with leading some of these HFEA committees. Can you tell us a little bit about the HFEA and what it does, and maybe some of the
yeah,
projects?
yeah. So the HFEA is the UK regulator. It's a government arm's length body. It's a UK regulator of IVF treatment and also embryo research. So it has its treatment, but also research. It was set up in 1990, so it's been around a long time now, and it or early and it um, all IVF clinics in the UK are licensed by the HFEA. So the HFEA goes out and does regular license inspections, and a clinic can only continue to offer IVF. And there was one recently in London that was shut down for a while, actually, because there were concerns about how the IVF was being done there. So it just goes to show you that clinics have to have a license to keep on offering. But the other part of what the HFEA does is it makes sure that patients are well informed from clinics, but also from the HFEA. Um, the committee that I chair on the HFEA is it's called SCAC, but it's responsible for sort of horizon scanning what new treatments are coming into the UK that we perhaps need to be regulating. But also a big part of it that I know you were involved with beforehand is the IVF add-ons. So what add-ons are out there? What's the evidence for them? There's a rating system that we have. Should they be widely used? Should they be never used at all? Or should they be used just after discussion in certain patient groups?
Let's dig a little bit deeper into that. So, could you just explain first, if a couple are going through IVF, what happens to them, and then we'll talk a little bit more about these IVF add-ons. So
Yeah.
what happens to them if they're going through IVF?
So the main part of an IVF cycle is that the woman has 10 to 14 days of a daily injection just below the skin, so subcutaneous or subcut injection to stimulate the ovaries to get lots of follicles. During a normal menstrual cycle, there's only ever one or maybe two follicles there. That's not enough for IVF in general. We want lots of follicles. So 10 to 14 days of daily injections, probably two monitoring ultrasound scans to look at how the ovaries are developing, how the follicles are developing. Then an egg collection, which is done under sedation. Now, to stop the woman ovulating, she has to have a second drug as well. So there'll be a second drug added in that switches off the woman's ability to ovulate. Otherwise, she might ovulate, on a Sunday morning at 2 a.m. Before the egg collection was planned. So 2 weeks of daily injections, then an egg collection under sedation. If there's a male partner and we're using a fresh sperm sample, he'll be producing a sperm sample around the same time as the egg collection. Then the eggs and the sperm are either mixed together, that's conventional IVF, or sperm is injected into the eggs, that's called ICSI, if there's a sperm quality problem. The embryos are then left in incubators. Nowadays, the standard is to leave them in incubators for up to 5 days, which is called the blastocyst stage, when the embryo will have between 100 and 200 cells. Then at that point, either usually a single fresh embryo is transferred to the uterus and spare one's frozen, or sometimes all of the embryos are frozen. And maybe the woman will come back and have a frozen embryo transfer at a later date. So that's essentially an IVF cycle. It's probably from start to finish using a short protocol, which is commonest now. It's about 4 weeks from day one to the pregnancy test.
And the IVF add-ons. Let's go there, Tim. Tell us about IVF add-ons. What are
Yeah.
they? What are they doing?
So again, I know I keep saying 10 to 15 years ago because you and I have been around a long time, Joyce. But if I think back to IVF, 10, 50, certainly 15 years ago, so heading back to sort of mid noughties up to 2010, everyone did IVF the same way. If you're anywhere in the world, you had a standard IVF cycle, which was basically just as I explained to you. So 2 weeks of daily injections, egg collection, fertilisation, culture the embryos to day 3 or maybe day 5, but that was just coming in then, and that was it. And then I vividly still remember the first time a patient came in to me and said, well, I've this is before social media really, because Facebook was just getting going. And patients coming in and saying, I've heard about this thing I can have injected into me called intralipids. I want to have that. And I never even heard of it. So I went away and, Googled or whatever we used back then, looked at it, and it was a fat solution being put into the veins. And I thought, that sounds like a load of rubbish to me. So I did some research looking at the different things that have been published, of which there was nothing, and there's still nothing. And I said, well, I don't even know what this is, but there's just nothing on it at all. And that was the first time I'd sort of heard of something that was an add-on. And then in about 2016 or 17, there was a Panorama undercover program looking at, there was an accusation that some clinics were selling add-ons, which are things that are added on to an IVF cycle that are not absolutely necessary. So everything I explained earlier on is how an IVF cycle works, but add-ons might be things like intralipids or immune testing for natural killer cells, time-lapse incubators, genetic testing of embryos, so PGTA. There are loads of them, of different ones. Some of them aren't used at all or very rarely. Some of them are used very frequently. And so there were concerns that add-ons were being missold with claims that just couldn't be backed up. And so the government asked the HFEA to look into this further, and then the HFEA came up with a traffic light system that obviously you were involved with, where add-ons were rated. And then most recently last year, because I now chair that committee, we evolved it further into 5 outcomes rather than 3 outcomes. But yeah, people could look at the hfea.gov.uk website. The add-ons page has got it there. And very importantly, all the studies that have been used to rate the add-ons are all there. The minutes for the committee meetings to discussing the pros and cons. It's very, very, very transparent. It's all there. And then I know ESHRA, around the same time, the last year or two that you were involved with, Joyce, ESHRA also did a similar piece of work. It was broader in terms of the net was wider in terms of what was an add-on, and the methodology was a bit different, but the results were pleasingly very, very similar.
Yeah, so ESHRA is our big European Society for Human Reproduction and Embryology. It's a big fertility society. And yeah, for my sins, I've spent years looking at the data on all the clinical studies, either for the HFEA or for ESHRA, about these add-ons. So we both wrote recommendations. And we both said there were many procedures that we didn't recommend, the HFEA and ESHRA, but they're still being offered, aren't they, Tim? There's clinics that still just offer this whole list of IVF add-ons.
Yeah. Yeah, I mean, so the HFEA approach is that, well, first of all, the HFEA has no regulatory authority to stop clinics offering add-ons. There's nothing that can be done about it. The Advertising Standards Authority can get involved if things are being promoted with no basis to them at all. The Competition and Markets Authority are looking at it. Obviously, you've got the GMC and the CQC, which are other regulators as well. But the HFEA cannot stop clinics offering add-ons. All we can do is to rate them. So there are some that are red, which means that we believe this add-on actually is either dangerous or lowers your chance of having a baby. And there are add-ons out there that are like that are being sold to patients. Now, my view is that I don't believe that add-ons should never be used. I mean, that's not my view at all as a working IVF clinician. And I think there are things that are amber on our rating system where it means that studies are conflicting. And on the ESHRA system, it says that maybe possibly used. It's a similar sort of thing really as it's in the middle. Studies are a bit conflicting. And my view is if a patient is fully informed and the people speaking to them say to them, these are the pros and cons, and we're not recommending it to everyone, but maybe in your situation with what's happened, if you want to try that, that's fine. It's up to you. I'm okay with that for things that are sort of amber or even maybe even grey, if people are fully informed about it. I'm not so sort of black and white that no one should ever use an add-on unless it's been proven to work, because I think sometimes that threshold is quite high.
I was that vulnerable fertility patient. I tried quite a few actually. I did reflexology, I did acupuncture, I've done quite a few that are on the various lists. And for me, the IVF add-ons has been something that's been haunting me since the 90s, because it was about 1994 when I was working on genetic testing of embryos that the first suggestion of genetically screening embryos for all IVF patients could be done. And that was, for me, the sort of original add-on. And we're still at a situation now, decades later, where we've got no evidence, in my view, that it does any advantage to anyone. There may be some things. I'm not convinced by the reduced miscarriage. I'm not convinced by the quicker time to pregnancy. But I think there's a lot of information out there suggesting that it's going to improve your chance of getting pregnant. And I just can't see that from the data. I really can't see that. So we're a bit scarred from it, aren't we, Tim?
I agree. I mean, the PGTA is an interesting one. So that's where embryos are grown to the blastocyst stage. They're then a laser is used to make a hole in the outside of the embryo. Some cells are taken away. The embryos are frozen, or blastocysts are frozen, and then the removed cells are then analysed genetically, which obviously, Joyce, that's your background for looking for inherited disease. But you can also do it to see which embryo supposedly got the right or the wrong numbers of chromosomes within, because that's the commonest cause of embryos not implanting. Now, in my view, there's been massive overselling of PGTA and hugely inflated claims of the benefits of it. But I do really believe that there are some patients where there are benefits in doing PGTA, perhaps older ones who have had a number of miscarriages and are looking at IVF anyway, that if they have a good ovarian reserve and are producing a good number of blastocysts, would rather know which ones are more likely to implant than other ones. But the problem with the test is it's not a completely black or white answer that says this embryo will implant and that embryo definitely won't implant. And there's that grey area in the middle, which is obviously the ongoing issue, and the fact it's expensive and it involves biopsying an embryo as well. So there are many, many negatives to it. But I don't think it's something that should never be used. I think there are some benefits, but nowhere near as widely as is spoken about, in my view.
Yeah. No, I totally agree with that. Anyway, let's move on to the future. So we've done a lot of research on a technique called in vitro maturation, and we've got other new technology bubbling under. What would you like to tell us about new developments in fertility treatment?
Well, I think the IVM stuff that I went to Canada for 2 years and did 25 years ago, I think, to be honest with you, that's had its day actually now. I think it's there are other techniques that have come in, such as the short antagonist protocol IVF that have very much taken away the benefits of IVM. The main benefits of IVM were a lower or zero risk of OHSS, overstimulation, which is the main health risk of IVF. I think it's had its day IVM now. I think in terms of what's coming next, there's quite a lot of stuff out there. I think there's a lot of research at the moment on the microbiome. Now, again, this is a classic add-on that's being sold to people. Get your microbiome measured, and then take some lactobacillus. And I was in a meeting earlier on where this was discussed. There's just nothing published on it at the moment, but there are some very poor quality studies suggesting maybe there's something in it. Well, that's great. Let's wait. Let's get those big quality studies done. And if it is such that testing for the microbiome and having treatment for it, a very easy treatment, is a benefit, that's great. This is being studied in cervical cancer at the moment. I mean, it's a really hot topic. So that may be something. Obviously, it's pretty low tech. In terms of the higher tech thing, this something called IVG, or in vitro gametogenesis, which essentially is lab-made eggs or sperm, which sounds really science fictiony. And we had a presentation earlier this year, actually, to the HFEA for some world experts in this, and I had no idea this is as close as it is. I
Yeah.
did not know. There are firms out there. There's three main firms in the world that are already very close to producing human eggs, egg-like structures from mouse swabs, and then the same sperm can be produced. They're also looking at if you have, if a man with XY, you can make eggs and sperm from a man. So that's how you then potentially fed a male gay couple. That eggs could be produced from one, and then sperm used from the other. And this is not science fiction. This is, in the next 5 years or so, is going to be coming in. How do you regulate that? Does this mean you can, a film star can sell, or someone walks past you, scratch them, you get some skin cells, you maybe could make 1 million eggs from Beyonce. I mean, literally the sky's the limit. So it's being sold in a way, there's a lot of money coming into this from private equity, because it might be a way of, you mentioned menopause, avoiding the menopause. Is that a good thing? Is it a bad thing? Do women want to be going on forever like that? But from a fertility point of view, the eggs running out, it's a low egg number and low egg quality. It probably will be a way around that. But what's the safety of it? Are these eggs really like proper eggs? So IVG is pretty close to happening, and that will be transformative in terms of human biology.
Yeah, I totally agree with you. I keep telling everybody that it's 5. It could be. It might not be, but it could be 5 years. And they're like, no, it's not. And I said, one of my alumni is running one of those really big companies in California. So yeah, I'm very, very aware. We went to visit them last year. I think it's very close. And I worry about the word artificial. So they are still from us. So if I needed some eggs, we could just take some of my skin, or as you said, some cheek cells, and then they do all this magic in the lab. They zap it and do these things. They make them into stem cells and things, and then they make it into an egg. Or if it's a guy, they can make eggs and sperm. So I think this would be an absolute game changer, because what you've said about female fertility declining and low success rates of IVF, etc., this would change it, because you could have thousands of eggs. And thousands of eggs from Beyonce.
Yeah.
So
Yeah. But very importantly, the bit that we're struggling with from HFEA point of view, or worldwide struggling, how do you regulate it? So in Japan, it's been banned, so they can't even do research into it, or they can't try and fertilize them at all, because these aren't eggs. If you have in vitro made eggs, so that means in lab made eggs, in lab made sperm. Well, these are not eggs and sperm. So the whole regulatory environment in the UK and around most of the world is about regulating human eggs and human sperm. Well, these are not human eggs and human sperm. And then, even if they look like human eggs and sperm, they've not come from the ovaries or from the testes. So the regulatory bit of that is something that has to be looked at very, very closely.
Yeah, it's gonna bring up lots of ethical problems, because I don't think we should be trying to delay the menopause, but we can, if we had some eggs, these grown in the lab eggs, and say for me, I could still get pregnant with them, because my womb stays pretty much okay. So even though I'm postmenopausal, women could absolutely still get pregnant. So
yeah, and I think as well, obviously we've spoken about maybe, but I think also clearly there's women who can never have a child of their own because they have had ovarian failure, ovarian insufficiency from before puberty or very early on. And so IVG, in vitro gametogenesis, is a way of giving fertility to people who either have no sperm or no eggs of their own to use. So there are very much medical treatments benefits of it, but the money is flooding into these companies not for that. It's for the much wider use, as you said, for women perhaps in their 40s, an easier way of getting pregnant, or 50s, and also not having to go through IVF, because you could produce 10,000 eggs. I mean, it would just be limitless.
I always say Brave New World. Aldous Huxley,
Yeah.
wrote that book 100 years ago, and some of the things he's predicted in there, they're happening for sure. But before we go on to the final questions that I ask all my guests at the end, one more question about assisted conception. What are the biggest myths that you have to spend your time demystifying?
It's interesting. I think most people actually feel it's more successful than it is. So generally, when people come in and they ask about it, they're very surprised. Even if the woman is 34 years old, they're very surprised that maybe the live birth rate in a good clinic is 40%, because they're fit and well, and they're thinking, well, I thought it was going to be 80% or 100% even. And then the other one is that that women who come in, they might be 40, early 40s, come in and are very fit and well, gym going, completely normal weight, eat healthily, and then are really shocked that the live birth rate in the UK for a 40-year-old, live birth rate having IVF is about 15 to 20% per cycle, and are really stunned by that. So I guess the big myth is that IVF is more successful than it really is. And I always explain it, it's a bit like people trying to get pregnant naturally. It's a case of just trying for a few. I think you have to go into it thinking you might need a few goes at it, which unfortunately obviously can get expensive. That's why the NICE guidelines say the NHS should be funding 3 cycles, and it's because of that cumulative success rate can add up.
Yeah, definitely. Right, my last questions I ask for all my guests, just a bit of fun. Tim, what makes you happy, and where is your happy place?
Well, I do quite. I really enjoy motor racing. So I'm racing at Silverstone in about 3 or 4 weeks' time. So on the Grand Prix track in an old early 1960s single-seater Formula One car, that makes me very, very happy. I play guitar and sing in a band. I'm an aging rocker. I was at Glastonbury last weekend, and I was at Wembley last night seeing AC/DC. So playing in my band and singing away, that makes me very, very happy. Spending time with my better half Jay, spending time with her, I love, and obviously spending time with my children as well. So those things make me happy. Plus, of course, work.
Work. We won't mention work though. I love music so much. I'm always at gigs and things. I'm always out day raving, and people get a bit shocked. It's like,
yeah, but you're a bit of a raver though, aren't you? You're a raver. I'm not into rave music so much. I'm into guitar-based music rather than electronic. But yeah.
Yeah, I wouldn't. I saw many friends at AC/DC last. I saw the picture of you on Instagram, but we're just having fun. We just life's there.
Exactly.
Life's there for the living. And the very last question: what advice would you give your younger self?
I probably learned to play the guitar better, so I could have been a professional rock musician and gone off down that route rather than being self-taught. I've always, I just through people, I sort of know people who are full-time professional musicians in some pretty big, well-known bands, and I always look at them very enviously. And they always say to me, Tim, some of them actually said, about our life's not fulfilling. We're not helping people like you are, which I guess is true, but I'm still very, very jealous.
I'm very jealous. They are helping people. They're giving us lots of joy. My goodness me. What could be more fulfilling?
I agree.
Tim, in another life, I definitely wanted to be a rock chick. I wanted to be that singer in a band. I couldn't, you and I love public speaking. We're sort of doing our, not quite the same performance.
It's because we're show-offs.
Yeah, but I mean, you're singing now, which is great. I really can't sing, but I do want to form a rock band, and I can play keyboards, and I've got a tambourine.
Well, we're looking for a backing singer. We're looking for a backing singer, Joyce. So we'll get you to one of our gigs. Even if you just want to play the tambourine, you're sorted. You're in the band.
Oh, I'm there. Tim, what's your band called?
Mojo.
I love it. I love it. No, we were at the British Menopause last week, and so many of us said that we wanted to be in a band. And one of them's just been learning the drums. One of the female
Excellent.
obs and gynae doctors. And one of the women I've interviewed for my book, she's 64 and she's just been on a 3-month course for DJing.
Excellent.
I love it.
I love that. Love it.
I love it. I love it. Hey, tell me when I'm coming to play my tambourine. I've got some
I will
maracas as
do. I
well.
will do. I will do. Perfect.
And
Perfect.
a triangle and percussion. Percussion's my thing, definitely. I can rattle things.
Yeah.
Oh, Tim, that's
Okay.
been really great, really great. I hope people learned something about how to become a parent, how to get pregnant, and really, I think it's so essential. And please keep doing all your work on social media because you're just you are the perfect person to be out there telling everyone, helping educate. And I will put your links on the show notes, and also for those that want to know a bit more information. The international group that I've been chairing, we've been writing information leaflets. So there's one on PCOS, there's one on IVF, there's one on ICSI. So they're going to be out any day. They've almost all finished. So they'll be out this summer on our website, which people can find quite easily. So it's really important for people to understand this and learn more as they go through this journey. So Tim, thanks very much. It's been a total pleasure, and enjoy your motor racing as well.
Pleasure.
Bye.
Thanks a lot, Joyce. Thank you. Bye.